No, I was just saying thank you very much, Joe, and the Ocumel team for giving me this opportunity. It's my very first time to one of these conferences. And I'd probably echo what Dr. Pavan said earlier, that doctors are pretty bad at this sort of thing, and particularly my background, I'm an ophthalmologist, and then I did ophthalmic pathology, so now more on the diagnostic front. We hardly see patients. We're the ones that give the diagnosis, but we don't actually get to see you. So it's really a great opportunity to come and actually meet you and talk with you. So as Joe mentioned, my topic, I was hoping to give you sort of a whistle-stop tour of conjunctival melanoma and its precursors, and the sort of research that we're hoping to do in Liverpool. So as you might be aware, conjunctival melanoma is particularly rare. It's much rarer than uveal melanoma. It's you get up to, the global incidence is anywhere from about 0.5 to 1 case per million per year, and mainly in sort of the fairer skin or the Caucasian. So you've got cases from North America and Europe, and a lot less from sort of your Afro-Caribbean, Asian backgrounds. Also probably because the data is less well documented that we have. It is intractable. I mean, conjunctival melanoma, unfortunately, the nature of the condition, it's multifocal, usually unilateral, but multifocal, so it's difficult to excise the tumor. So you do get high incidence of recurrence and all the complications with it. You do get significant side effects and reactions from the tumor itself in terms of not just the cosmetics, but a red eye, burning, irritation, and the other extreme of actual visual loss, and it's permanent visual loss as well. So it is poor quality of life because of not just the cosmetic effects, but all the symptomology that you have from the disease itself. There is no standard of care. So uveal melanoma is much more researched than conjunctival melanoma. So unless they are seen in a specialized ocular cancer center, the treatment varies considerably. And because conjunctival melanoma is small, and unless the eye is examined where the lids are averted, so you're turning over the lids, they can be missed altogether or misdiagnosed because they take a range of presentations. They're not necessarily pigmented. They can be sort of the whole spectrum, non-pigmented to pink to sort of brown to black, and they can mimic quite a few other diseases, so they're not readily picked up. I'll warn you now, so this is a video that I'm about to show, so if you want to turn away if you don't want to see the video, and I'll let you know when the video's over, just how conjunctival melanoma is actually excised. So if I can... So because of the risk of seeding, you first make a burn mark around the tumor, so you're demarcating the borders quite easily. You then excise the tumor. It's removed on block, so in one whole block, because you don't want to fragment. You also want to keep the tumor whole because you don't want to risk seeding, and in other words, leaving tumor cells elsewhere in the eye. There's a change of instruments, and then it's showing alcohol to actually kill the remaining bits of tumor that might be left. It's then stitched up and closed, and it's about to finish. I'll let you know, though. This is just how it's actually closed. And this is towards the end of the operation. So that's at the end where the tumor is actually removed. Time is given for the tumor to actually heal, and then you can put a plaque radiotherapy, so the brachytherapy, like you treat with uveal melanoma, just to kill any residual tumor that might be there. Because, as I say, that was a nice tumor nodule. Sometimes you do not get that. It is multifocal, so to make sure you've covered a bigger area, and if there is any risk of tumor seeding, you're getting rid of that tumor. I just put that schematic on of the stages, just in case the video didn't work, but that goes through the steps of excision and then the plaque. So those are just the pictures of the tumor and the eye. I'll move back because there's a picture that I'm just about to show that if you want to turn away again. I don't want to. So besides that, if I can just go back, sorry. Let's go to previous. So yes, worst case scenario is if the tumor becomes bigger and you have to remove the eye because it's spread into the other tissues, then this is what happens, and this is what we then see, which is the slide picture of the tumor in situ in the actual eye. Let's go to next. And that's the last of the gory images. Post-operative complications are high just because of the nature of the disease, with its multifocal nature, the late diagnosis often, but also the treatment itself. You've got side effects of the plaque brachytherapy. If it's proton beam therapy, if you have the excision, you've got the scarring. And then a lot of these are treated topically with chemotherapy. So those in itself, they're quite cytotoxic. In other words, they do affect the ocular surface. So people do get a lot of eye symptoms in terms of burning, red, painful eye because of the treatment itself. Recurrence rates are high. So about a third of these cases to about 45%, you do get recurrence. So that's why with this kind of condition, it is also lifelong follow-up. Here you do develop secondaries, but rather than going to the liver, the secondaries are more from the drainage, the lymphatic drainage. So it's mainly effects to the lymph nodes in your neck region, so below the face and neck region, and about 25% will spread to the local lymph nodes. Now, depending on the location of the tumor, so if it's, it can affect any part of your eye or under the lid, but if it's particularly close to the nose, then they recommend frequent scanning of your orbit and the nasal system, because the melanoma can spread into that as well. But a percentage, probably about 10%, can go elsewhere and spread to the liver, the lungs, and even the brain. Now, unfortunately, very little is actually known of the precursor lesions, so what leads up to conjunctival melanoma. So conjunctival melanoma is more, it's known as a cutaneous, it's a mucosal melanoma. So it's more similar to your skin melanoma as opposed to uveal melanoma. Uveal melanoma is a completely different beast, in terms of its embryological development, the clinical, and also the genetic features. It's entirely different. Conjunctival melanoma is UV-driven, like skin, but it's much less understudied. And just to give context, uveal conjunctival melanoma probably only equates to about 5% of ocular melanoma. So with the precursor lesions being poorly understood, a lot of time is being invested into trying to understand the biology of these lesions before it becomes like an invasive disease. Because 70% of your in situ lesions will progress to melanoma. Rather than it being a nevus, only a small proportion comes from nevus. 70% actually come from a precursor lesion. So this is just an illustration. When we try to summarize all the genetic changes that we know of in conjunctival melanoma, as opposed to the precursor lesions, the NAD actually stands for no available data because it is that understudied. And we are lucky in Liverpool being one of 3 ocular oncology centres with their associated specialised pathology centres, so receiving pathology from the region. We've got 3 in England, Liverpool, Sheffield and London, as you're all well aware, and you've also got Glasgow. Also, we tie in not only to our local services in terms of oncology with the Clatterbridge Centre, we speak a lot to the other pathology centres that also receive these specimens. And through our associations with the European group, we can study these samples together. And we have done studies where we've taken samples, because conjunctival melanoma, in Liverpool, we're seeing about 10 a year. So that just gives you perspective as to how rare it is. So in order to study this disease, we do need to pool in efforts from countries elsewhere so we can really study this entity properly. The Liverpool Ocular Oncology Group, it's one of a kind because they have a unique biobank which has these samples and other ocular tumours collected over the last 15 years with follow-up data for these patients, their genetics, and it is one of its kind. So they have contributed a lot to international and national studies for samples. So the reason I've put this slide is because that's where my samples are coming from, but also the European Ophthalmic Society, the British Association, and the European Ocular Oncology Group is also where we're going to be taking samples so we can do this research. So just to give an idea, the precursor lesions I was alluding to, this is not for you to read, but just to give you that over the decades, those are all the different terminologies used for this disease. And it's only up until recently, the ones in the red box are the ones that are used. Primary acquired melanosis typically is being used in the States, whereas the conjunctival melanocytic intraepithelial neoplasia, like lesions, the precursor lesions, is what some of Europe and here that we're using. Having said that, there was a real conscious effort by the WHO to try and bring everyone together so we have one grading system. And the reason for that being because unless you have an accurate diagnosis and grading system, you cannot inform your clinicians of the treatment thresholds. And that's why there is so much variation in care amongst the centres. So one classification, the WHO came up with a simplified classification for all those different ones that you saw in the list to unify all diagnostic laboratories into subdividing these lesions, those that can be sort of discharged, patients can be safely discharged, those patients that can be followed up, and those patients that do need aggressive treatment. However, the study was quite limited. We're talking about small numbers. There's only 83 biopsies. It wasn't on the complete set that you take, and we didn't have cases of recurrence and invasion. And there were some weaknesses in this system. So in giving that system, the WHO 2022 revised it and incorporated, some of the weaknesses of the previous study. And we then revalidated that just in 2020. It was only published last year about how these lesions would be graded, not only to inform the clinicians, but also so we can predict which cases are going to recur and which ones are higher risk to progress onto the invasive disease, to reflect the actual biology of the condition. And we created an atlas of how to diagnose these lesions that can be used worldwide then. So everyone is talking on the same page. Now taking you on to what we're hoping to do in collaboration with others is to understand what actually drives this disease. So from its development to actually its transformation to then its progression. So the first aim of my project for this is to actually understand the molecular basis. So looking at the genetic fingerprint, the genetic makeup of these diseases, and going from not including the precursor lesions, so the early stages of the disease, to when it becomes in situ, so it's just about to become invasive, and then the actual full-blown conjunctival melanoma. And the reason for this is that if we have the genetic makeup, we can tie it with the clinical features that the ocular oncologist sees in clinic, with the diagnostic features as pathologists, then we have a data set that we can use to, one, risk stratify these patients into low risk, high risk, which would need closer follow-up, and then inform the treatment thresholds, who can be safely discharged, who needs to be followed up, who needs to be treated aggressively, because the treatment is aggressive. And also then, especially in the era of personalized medicine, you want targeted treatments. There's targeted treatments for all sorts of other cancers, and we're seeing sort of targeted treatment for uveal melanoma, but we don't really have that for conjunctival. So that's the first step. The second step, when you have the genetic makeup, is to see what proteins, because proteins can be targeted. So what these cells are actually doing, what they're secreting, and how they can be targeted. And you have gene expression, but genes always don't give you a target. Some genes are closed, switched off, some are switched on. So one way of targeting them is by validating it by what the cells are actually secreting. So it's looking for the actual proteins in each of those stages, so we can make a complete data set and hopefully identify protein targets that we can then treat. So how we propose to do this at the moment, we've got the ethics for the project, where we have the samples and are recruiting more. But because this hasn't been done at all, we're at the pilot phase where I'm going to be comparing the invasive disease with just the in situ disease. So at the pre-invasive. And then the hope is that once we have this pilot data, we then do the entire spectrum. So if we have that, we can treat even earlier than what we're doing at the moment. So this is taking the melanoma samples just before it's invaded, and then it becomes invasive disease. These will then be put on a slide that can be fed into a special panel to look at the whole genetic makeup of those tumor samples. They are then sequenced and analysed, and tying in with this, we'll also be looking at the mutational status of these, because mutations also govern not only the treatment, but also how these patients are actually going to do in terms of prognosis as well. Like you've heard for the genetics and the mutations in uveal melanoma, like the BAP1 and the chromosomal abnormalities, the same thing we'd hope to work up in the conjunctival and relate this back to the rest of the genetic makeup, the clinical and the histomorphological features. The second phase of the study is then looking at the protein markers, because the proteins can then be targeted. And one, it's not only just to understand the disease biology, by what proteins, what pathways are implicated in the disease, but then also identify where we can intercept and treat the disease. And there are several, it's also not to reinvent the wheel. You have personalized treatment for other for cancers, such as particularly lung, your GI, breast. It's whether those drugs can also be refurbished to be used for this. So you're not reinventing the wheel, you're actually seeing what is available there. So that would be the second phase of the study. And there's very clever bioinformatic pipelines that can actually look at a whole wealth of data, compare it to other cancer types, and see if there are targeted treatments that match that we see in conjunctival melanoma that can be used here. So this is at the sort of the laboratory side. The next stage would be then to look at the entire spectrum of lesions. So you're going from the very beginning, where you're even classifying the lesions as benign, right through to the invasive disease. So we understand the disease biology. That would be the next step. But obviously, with these being rare tumors, it is collaborating with people worldwide to get more samples for this. And then we would go to the preclinical testing. So before anything can be done to the bedside, the preclinical testing is looking in three-dimensional models of the disease, and then also doing in vivo work, and with conjunctival melanoma, with it being on the surface, and rather than going to animal models, we've already got groups who are looking at the chick embryo model, where they're trying to grow these onto the membrane of these tumors, then look at them, but also look at drug delivery systems. So use of in synthetic biomaterials to actually precisely deliver the drug. So this is also work that's going alongside at the moment. Once you have the preclinical studies and you've got the validation data, then eventually the aim is to go to clinical trials with those treatments against the specific proteins that we find from this. So that would be going into multicenter clinical trials that you're more familiar with, and actually make conjunctival melanoma better known, because in the International Rare Cancers Initiative, you've got uveal melanoma. There is no mention of conjunctival melanoma there. So it's also bringing that recognition forward for conjunctival melanoma. And those are all the people that are involved in this project, so thanking each of them for their input. And this is the laboratory team as well as the clinical team, and our collaborators and our funding. Thank you very much for listening.